Assessing Risk and Managing Behaviors in Persons with Dementia. This is the third installment in the fourth Mental Health and Aging Training Initiative series of webinars initiated by the Geriatric Mental Health Partnership, which is an informal, voluntary group of diverse stakeholders which focuses on geriatric mental and behavioral health care in the Commonwealth of Virginia. This webinar will focus on tools and techniques that can be used in risk assessment and addressing behaviors in individuals with dementia. This event is made possible through a grant from the Virginia Center on Aging's Geriatric Training Education Initiative and is supported by Riverside Center for Excellence in Aging and Lifelong Health, the Virginia Geriatric Mental Health Partnership, and VCU's Department of Gerontology. Today we are quite fortunate to have two presenters with us today. Cindy Mann, who is a unit manager at Centra Senior Psychiatric Program, and Beth Ulrich, who is the community liaison with Centra Senior Psychiatric Program. I'll refer you to the webinar hub for presenter bios, series summaries, and additional details and contact information. I'd like to thank the Geriatric Mental Health Partnership Planning Committee for their efforts in securing these topics and presenters. As always, I'd like to thank Nico Stankulescu, our platform facilitator with World Events Forum. She puts in countless hours behind the scenes to bring these educational opportunities to you. And I'm Ann Welliford, your moderator, chair of the VCU Department of Gerontology in the School of Allied Health Professions, and I'm also a member of the Geriatric Mental Health Partnership. I'd like to share a couple of housekeeping details before I pass our session over to our presenters. First of all, I hope many of you have had the opportunity to download the slides, which are available on the webinar hub for both note-taking and sharing. Please be certain to complete the surveys that you will receive following the webinar. These surveys are from our funders, and it makes it available to you for these webinars to be free. So please take the opportunity to complete those. This is also how you will receive your certificate of attendance. Throughout this session, you will have the opportunity to pose questions for our presenters if we have time for question and answer at the end of this session. So at this time, I would like to take the opportunity to again thank our presenters for being with us today and pass the microphone over to them. So I'm going to pass it over to Cindy and Beth. Thank you.
Thank you, Ann. I appreciate that. Thank you, Nico. Good afternoon to everybody. I'd like to thank you for allowing us to spend some time with you and to share some information with you that has helped us to better care for those patients with cognitive impairment. As mentioned, my name's Cindy Mann. I've worked with the psychiatric patient population for the last 30 years. I've worked both inpatient and outpatient. And the majority of my time is spent with the elderly, specifically those affected with dementia. My topic of presentation today is assessing risks in dementia patients. In order to fully understand the situation, several areas must be considered. One of the things that I like to consider prominently is what is that exactly is the problematic behavior? Is the person becoming fatigued or sundowning? Are they getting more confused, more irritable in the latter part of the day? Are they wandering? Are they looking for things they can't find or seem to locate? Or are they just restless and searching for things? Are they hiding their possessions because they are paranoid or because they've lost things and they maybe believe that things have been stolen from them? Is their behavior problematic because of combative behavior with interactions, such as during bathing or toileting? Are they having catastrophic responses to behaviors that embarrass or frighten them? Are they verbally aggressive? Are they yelling or cursing? Or are they frustrated because they're frightened or irritated enough to become physically aggressive? One of the behaviors that is once the behavior is identified, we need to consider the disease process itself to better understand the behavior. In order to understand the obvious behavioral changes, it helps us to understand the underlying cause. The different types of dementia affect the brain differently. as well as the area of the brain that's affected and the stage of the disease. Although a lot of times people think anytime they forget something or they get forgetful, they'll say they have dementia, or specifically they'll say they have Alzheimer's. Dementia itself is not necessarily a disease. It's a group of symptoms that affects intellectual and social abilities severely enough to interfere with daily functioning. That would be like saying, if they were to say that they have dementia because they have forgetfulness, that would be like saying that someone has cancer. They have many types of cancers. They have many symptoms of cancer. They have many interventions that can be utilized. Alzheimer's disease is just one of the most prominently known and one of the most recognizable. Some of the most common types of dementia identified are Alzheimer's disease, vascular dementia, Lewy body dementia. Dementia is associated with Parkinson's disease, and you'll see with that, you'll see Pick's disease, and frontal temporal lobe dementia is another one as well. There are dementias associated with diseases such as Huntington's chorea, and you'll also see dementias in people who have chronic alcohol and drug use. There are also patients who have what is referred to as a mixed dementia, which means that they have two types of dementia combined at the same time. Probably the most widely known type of dementia is Alzheimer's disease. It's shown to be an atrophy or loss of brain tissue. The brain disorder is identified by increased confusion, increased anxiety, increased frustration. It affects about 5% of those people at age 65. And by age 85, it's 50% of the population. Usually it has late onset, and it's fairly slow progressing. The average length of the disease is usually 6 to 20 years. Usually what you'll see with Alzheimer's is basically a reversal of the life cycle. Initially, you'll see people who act more like a teenager. They may be impulsive with their decisions. They may make decisions without processing the logic of the situation, such as spending money without being accountable or interacting with strangers. Gradually, you may even notice behaviors similar to a preteen. They want to go somewhere, but they have no idea how to get there. Or as they lose their executive function, they may not be able to pay their bills or organize activities. Eventually, they'll behave more like a toddler. They may dress inappropriately for the situation or for the weather. They may throw temper tantrums, or they may have episodes of incontinence. Eventually, they'll progress to more infantile behaviors and will not eat unless fed and have significant difficulties with their gait and with ambulation. The next most common type is vascular dementia. Basically, that means that it's an impairment that is related to the vascular system of the brain, the blood flow of the brain. This can be the result of hypertension, stroke, head injuries, hardening of the arteries, anything like that. It's often also seen in patients with dementia or cardiac issues. Unlike the gradual progression of Alzheimer's, the changes associated with vascular dementia may be very sudden. Also, depending on the area of the brain that's affected, the behavior can vary greatly. If a stroke impairs the speech center, for example, you may notice aphasia. They may have symptoms of agnosia, in which they're unable to recognize objects or faces or voices or places, especially if there's any parietal lobe involvement. Lewy body dementia is another form of dementia that we see fairly often. It's one of the quickest to progress. It can be seen in those individuals that are younger than the stereotypical dementia patient. Often this form presents with very vivid hallucinations, especially visual hallucinations. These symptoms frequently are described as waxing and waning, meaning one day you'll have a very good day, the next day they're horrible. and vice versa. They go backwards and forwards. Also, these patients, despite having hallucinations, tend to do very poorly on antipsychotic medications, and they'll often become more disinhibited on them. One of the things that is a stereotypical problem with this is it does affect the younger people, but it also progresses rapidly, more rapidly than any other form of dementia. The length of illness is usually 6 years or less. Frontotemporal dementia is a dementia that affects the brain, that is in control of the personality of the person, the judgment of the person, the area of the brain that helps us to censor our impulsivity or our judgments. If there's damage in this area of the brain, you'll actually see distinct personality changes. You'll see temporal and demeanor changes. This is the time when you'll see someone who was very, very sweet and kind, and all of a sudden they're cursing like a drunken sailor. You will see people who have been very modest and withdrawn. All of a sudden you'll see people displaying very inappropriate, sometimes sexually inappropriate behaviors. They'll say things that they really should not have said. They'll do things that they really shouldn't do, and it's not directed towards the person that they're speaking to or acting upon. A lot of times it's totally without any kind of pre-thought. This tends to occur in ages that are younger, and it can be faster than the Alzheimer's type dementia, not quite as fast as a Lewy body dementia. The next thing that we have to consider in assessing people with behavioral risks is, are there any comorbidities? Is there anything else that might be going on? Is there a progression of the dementia, or is there an exacerbation of symptoms because of some other issues that are going on? When you look at the person, you need to identify, are there any changes in their hearing or vision that might be contributory? Is the person more confused due to delirium that is often caused by infection or other physical issues that are happening? Are they more irritable because they are in pain? When assessing the patients who have dementia, you also need to consider other situations that might arise. Elderly patients are at a huge risk for falling. You need to be able to identify if they're at an elevated risk for falling. So keep in mind that it might be related to vision changes, medications, especially those that are sedating, orthostatic hypertension. There's certain medications that will cause the blood pressure to drop when a person stands up, and they get very medicine-heady or light-headed when they stand up. Also, elderly have problems with muscle weakness and arthritic changes or orthopedic changes that might make them at a higher risk of falling. One of the other issues that needs to be considered when assessing a dementia patient and their mood and their behaviors, is there an underlying mood disorder? Are they depressed or anxious? That can happen as well as the dementia. Especially in the early stages of the disease, this might be more prevalent. When I'm identifying the risks with a patient that I'm trying to assess, I also have to keep in mind the suicide rates are higher among the elderly than any other group, especially elderly men. Even though patients in the latter stages of the disease are not able to formulate plans or complete actions like someone younger, those in the early stages of the disease definitely are. Many people are pretty devastated when they get the prognosis of a dementia. They're not able to consider living the life that they dread, especially if they've seen it in their family or someone they know. Things that need to be considered are whether or not they have a history of depression, if they've ever had any suicidal ideation or any attempts. You need to consider also, is there a family history? A lot of people are raised that suicide is bad. However, if it's already happened in your family, then the taboo has been broken. People are more apt to act on that. We also have to consider that medical advances have increased life expectancy. So those people are living longer. Quantity doesn't always match quality, though. You also have people that have a fear of institutionalization. I can't tell you how many times I've heard people say, I will never live in a nursing home, or please promise me you will never put me in a nursing facility. Also, as well as people living longer, they have greater financial stresses. Medicine costs money, care costs money, help costs money. A lot of times people haven't adequately planned for that, and that can be another stressor. As well as the stress of grief. As we're aging, we're losing family members, we're losing friends. Our career has ended a lot of the time. No longer are we as autonomous as we have been. We're not as healthy, and our financials aren't the way they used to be. So they have different grief issues. Also, you need to consider, is there an underlying thought disorder? If you have a history of thought disorder, people don't stop being bipolar. They don't stop being schizoaffective or schizophrenic when they develop the symptoms of dementia. So if they've already had trouble processing issues, thoughts, situations, and they become psychotic, do they become fearful? Is that going to lead to more problems with their behaviors? Another thing that I try to consider when looking at a patient and what's going on with them behaviorally is what precipitates the behavior? What are the triggers that are involved? Is there anything that made it happen, that led to it? There are many things that can be considered triggers or causes. Here are a few that we deal with commonly. Is the person overstimulated? I know a lot of times family want to include grandma or grandpa in activities or outings. Sometimes that's a good thing. Sometimes it's not a good thing. If they've got too much going on, they're processing more than they can deal with, that becomes frustrating and overstimulating. Another thing, especially with like the sundowners, you'll see fatigue. By the end of the day, they're tired. They are worn out. They're less apt to deal with things appropriately. You also need to consider, is there a change in residence or caregiver? A lot of times, anytime a patient will come to a hospital, they're more apt to act out than when they were in the facility or the home that they were at originally, because they don't know where they are. They're out of their element. They're out of their residence. They're out of the group of people that they recognize, so it's frightening to them. You also need to consider, are they able to interpret or are they misinterpreting the situation? A lot of times if you have someone who doesn't understand, they may jump to conclusions, even if they don't realize they are. If you hold out your hand to somebody, are they thinking that you've just attempted to smack them, even if you're trying to hold their hand or to shake their hand? And also, are they having any kind of symptoms of receptive aphasia, meaning they're not able to process what they're hearing and the words that you're trying to tell them? So they don't understand what language you're speaking anymore. And sometimes they'll have expressive aphasia where they can't tell you what they want to speak. So it's hard to interact with someone when you're speaking in two different languages. The next part of my assessment as a nurse is to know the person and know their life story. To better understand why a person responds the way they do, you need to understand who the person is and who they've been. That's whether they have dementia or not, in all honesty. A lot of times their behaviors or responses are related to whether they've had a traumatic or abusive history. They may respond differently if their lifestyle or work history affects their current status, their level of education, the relationships that they've had, their religious or cultural backgrounds, as well as their medical history. I've had patients in the past who we just could not get them to sleep. They wanted to sleep all day and be up all night. To somebody that is used to the typical daytime cycles, that's problematic. But when we understand that maybe that person worked third shift their entire life and that's normal to them, it's easier to understand what's going on. Another thing that I try to use as far as assessment in a situation is their needs. Maslow nailed it. We all have to have our basic needs met. At times, individuals will behave in a way that they feel that they do because they feel their needs aren't being met. On my units, I try to encourage the staff to frequently make sure that the patients need to have their needs have been met in terms of what I call the 5 Ps. Do they need to potty? Have they been sitting in the same spot for a long time and their positioning is just not uncomfortable for them? Do they have any kind of pain or discomfort? Are their personal items in reach? And are they having enough to eat or drink? Of course, without any other assessment ideas, there are some tools and measures that have been developed that can help predict aggressive behavior, especially useful in the acute inpatient psych setting. Some of the ones that are most widely recognized are the BBC, the HCR-20, and the DASA aggression scale. Although nobody can predict the future, some of the things that you can look towards as far as trying to identify whether or not they're going to be aggressive in the future are things like irritability, impulsivity, unwillingness to follow directions, any kind of sensitivity to perceived provocation. Are they easily angered when their requests are denied? Do they have a negative attitude? Are they anxious or fearful? Do they have low empathy or remorse? Are they a past victim of sexual or physical abuse? And also look back, have they been aggressive towards objects the last couple of hours, last 24 hours specifically? Have they been verbally aggressive the last 24 hours? Have they been physically aggressive towards another person in the last 24 hours? And if they rate high on any of these, then you can predict that there may be some aggression building or coming forward. What do you do if you find out that they are aggressive, that they are potentially going to be problematic with their behaviors? One of the things that you need to do is identify the warning signs. The other thing that you need to consider is to inform those who are providing care so that they can be careful, so that they can increase their monitoring. There may need to be some changes in medications. And you may need to reassess your behavioral strategies. If something's not working, you need to fix it. And lastly, remain positive. Focus upon the feelings of the individual, not the facts. Sometimes it doesn't matter if they just broke something. You need to identify what the feelings are that led to that. And in most situations, just be aware that their behaviors are telling you what the person no longer can. Thank you, and I'm going to turn it over to Beth now.
Well, good afternoon. Now that Cindy has discussed the assessment process, I have the opportunity to discuss the challenges of managing difficult behaviors in dementia patients. I'd like to start with taking a look at some steps related to preventing problems When we talk about prevention, we are not only referring to preventing behaviors in our patients, but also preventing unsuccessful interventions and reactions from caregivers. So the basic needs include security, affection, control, and inclusion. Often challenging behaviors, including aggression, are the person's search for these basic needs. That is security, control, identity, affection, or a sense of purpose or achievement. Now, our ultimate goal is not necessarily stopping the behavior, but addressing the needs that lie behind it. So let's examine some fundamental questions. How do we perceive behaviors? Behavior is a person's effort to cope or to communicate a need, not something that must be eliminated. The approach, therefore, is to identify alternatives and increase understanding rather than imposing controls. For example, I was asked to help the staff at a long-term care facility to better address the struggles they were having with a female patient who was constantly on the call bell, demanding to use the bathroom. They also reported that she was always talking about her desire to go home. They identified her as attention-seeking, and they felt it was necessary to impose some form of control to stop these behaviors. Now, I'm going to be referring to this lady throughout the course of our discussion this afternoon. I'd like to suggest to you that rewards and consequences typically don't work with this population. Attempts to implement behavior plans are usually unsuccessful. Another fundamental question, how do we see our role with cognitively impaired patients? Is it paternalistic, or do we become the patient's partner? Paternalistic would be determining what she needs or what is best for her. But becoming her partner is actually entering her world. As Cindy pointed out, it's so very important to know the person's life story, preferences, including food preferences, values, activities, what some of their history included in terms of their vocation, that sort of thing. So what we want to take a look at is, should the staff tell the patient that she doesn't need to go to the bathroom so soon since she just went, and that they have other patients to take care of? Or do they try to understand what is behind her demands? Now, to give another example of how important it is to know your patient, we had an elderly gentleman on our unit a few years ago who was diagnosed with moderate to severe dementia. He was typically irritable, but generally cooperative until the nurses attempted to get him to take his medication. He often threw the medication at them, which precipitated other combative behaviors, throwing other objects at them, swinging at them, and just becoming much more difficult to manage. As we considered this dilemma, we acknowledged that this man had always been in upper management positions during his professional career, and he was used to giving orders and had a strong need for control, especially regarding his own choices. So when one of the nurses considered this, she changed her approach in administering his medications. Rather than simply giving him a cupful of pills and instructing him to take them, she took the time to explain each medication and its purpose to him. And the result was that he ultimately began to be more cooperative and compliant with his medications. How do we understand the behavioral and functional manifestations of dementia? Now, the caregiver must understand the disability in order to meet the needs of the patient. We have to be aware of such things as apraxia, aphasia, amnesia, agnosia, and executive dysfunction. I'm going to be talking about that a little bit further on in the discussion. So, do we ask our patients to do things that are impossible for them to do? Perhaps you might tell your patient to brush his teeth or button up his shirt. or stop ringing the call bell, or stop yelling. How do we respond to an individual's needs? The need to meet physical or psychosocial needs. Should the staff remind the patient that she just used the bathroom? How about security or restriction? How do we identify compensation measures to meet the needs of the patient? Do we provide specific activities and forms of assistance? Are we addressing specific needs? Should the staff inform her that it is not realistic for her to return home again? Well, now I would like to review with you the problem-solving approach that our treatment team uses on the geriatric psychiatric acute unit here at Virginia Baptist Hospital. It's the 4D approach from the book Practical Dementia Care by Ravens, Laketzos, and Steele. We have found it to be very effective. And the staff at some of our long-term care facilities have also begun to implement this process as well with some success. Now, it's a challenging process for staff to implement initially, but after some practice, it really almost becomes second nature. We all have a tendency to want to get a quick fix to problems. However, this process exemplifies the needs to do a thorough evaluation and analysis before proceeding to the treatment plan. So let's go over the 4Ds. First, we need to define the problem, making observations, addressing details, collecting facts. We need to ask the questions such as where, when, how, with whom, after, or before what occurred made the problem happen. Then we're going to move into the decode stage. The key question is, what may be contributing to the cause of the problem? Then we'll finally devise a plan. And then we'll ask the questions, what are we going to do? Ultimately, we'll determine what outcome was expected and did the interventions work. So first we need to define the problem. What exactly are difficult behaviors? As Cindy pointed out, they could be difficult verbal behaviors such as yelling, screaming, threatening through body posture, or physical behaviors such as hitting, pushing, shoving, kicking, or spitting. It could also include wandering or exit seeking, throwing objects, resisting care. The focus should be on the behavior, such as she hits while being bathed. Now, for example, a patient in a long-term care facility was very resistant to being bathed. She wouldn't even agree to allow the staff to walk her down to the shower room. Otherwise, she was typically fairly pleasant and cooperative. However, she became quite belligerent, swatting at staff, and would refuse to go to the shower room with them. So I'll tell you a little bit more about her later as well. Now remember, usually there's a precipitant or a provocation that can be identified related to the behavior. Serious problems leading to injury, distress in patients, and distress to others. That's something that we really need to be aware of. So it is important to describe the form the behavior takes, against whom it is directed, the context in which it occurs, the consequences such as injury. And it's also important to examine the time of day, the frequency of the behavior, and what the patient actually says. Now we're going to move into the decode part of the problem-solving process. Our colleague, Dr. Andrew Heck from the Piedmont Geriatric Hospital, developed an acronym of HERE, and I think it's very useful in terms of going through this process of decoding the problem. We have H, which stands for health and medical conditions, E for the environment, A for approach, and R for resident factors. So let's take a look at the health and medical conditions. As Cindy discussed, psychiatric history and disorder are very important to be considered in terms of identifying what might be contributing to the patient's problems and behaviors. It may be related to delusions, hallucinations, suspicious behaviors, or paranoia. There may also be some depression or mania or sleep disturbance, such as sleep deprivation. We also need to take a look at the medical history. Is there a delirium? Is there pain? Is the patient struggling with constipation? Could there be visual or hearing impairments? Are certain medications contributing to the problem? Are there issues with regard to hydration and nutrition? Remember, it's important to consider such things as delirium and evaluate for the possibility of a urinary tract infection or other infections. Perhaps the patient had a recent surgery with anesthesia and is struggling with a delirium that has changed the level of functioning and impacted the behaviors. I think we often overlook hydration and nutrition, and this is something that really needs to be considered. All right. A thorough medical exam, including consideration of psychiatric history, should be conducted. You also might want to include a head CT. Now, moving on to environment. Is it overstimulating or understimulating? Is there a lack of activity and structure, or perhaps there's too much activity? Is the patient being pushed? Is he being approached from behind? Is there inadequate communication? A supportive and attentive approach helps to prevent problematic behaviors. And finally, resident factors are important to be aware of. Be aware of the patient's needs, wants, habits, and desires. How is the patient who is resistant to going down the hall for her bath being approached? Does she respond more positively to certain individuals? Again, consider sleep patterns, favorite foods, hobbies, previous habits. Has the patient typically taken her bath or shower in the morning or in the evening? When dressing, did she put her blouse on first, or does she prefer to put her pants on first? Regarding the patient who stayed on the call bell constantly, it was identified that she had been an avid gardener. The lady who was resistant to walking down the hall for her shower loved to drink coffee. So keep those little tidbits in mind. Consider the symptoms of dementia or other cognitive disorders. Now, aphasia, as Cindy had pointed out, is an impairment of language ability. It can be expressive aphasia or receptive aphasia. So an individual with aphasia may be frustrated by an inability to express himself or to understand something being said to him. Agnosia is the inability to recognize objects, people, or places. Patient may not recognize a person who is approaching him and may strike out in self-defense. Apraxia is motor impairment. The patient might not be able to use eating utensils any longer or hold a pen, and this could be extremely frustrating to him. Amnesia is when there is difficulty registering new memories and recalling them. So an individual might tell the same story repeatedly or can't remember what he had for breakfast or even if he had breakfast. And as Cindy had mentioned earlier, executive disorder refers to difficulty planning, reasoning, and organizing information. So inhibitions related to aggressive urges no longer exist. One of our previous patients on the acute unit was admitted from a long-term care facility after having thrown a flat-screen TV at another resident. While this appeared to be quite aggressive and vindictive on his part, in actuality, he wasn't able to recognize the object and became frightened, which ultimately resulted in the behavior. Now, what's a catastrophic reaction? It is a sudden expression of negative emotion, crying, yelling, precipitated by an environmental event or a task failure. The person behaves as if a catastrophe has happened, even though the precipitant is minor. For example, you might ask your patient to button his shirt, to put his shirt on, and he starts yelling and screaming at you. Or you might serve the patient her breakfast tray, and she throws it at you. So this is something for you to keep in mind in terms of difficult and aggressive behaviors with your patients. Now, finally, we're going to be moving into the devise segment of the problem-solving process. Having defined and decoded the problems, we're finally going to be working on aspects of caregiving and a treatment plan. So we need to take a look at perhaps changing the caregiver approach, removing the precipitant, using distraction, staying calm. Keep the patient out of harm's way, even if it means grabbing her gently or blocking him. You may need to consider making environmental changes, and pay attention and spend some time with your patient. Develop a trusting relationship. Know how to identify precipitants, especially related to catastrophic reactions. We also might need to change the caregiver approach. Stop correcting the patient. Don't argue with the patient. Remember, the patient is always right. Walk away and try again later with a different approach. Show the person what you want him or her to do by demonstrating and praising non-verbally through hugs or a caring smile. Don't talk about the person in front of them. I wanted to back up a little bit and take a look at delusions and hallucinations. Now, what is a delusion? It is a false, fixed, idiosyncratic belief. Often patients identify that their spouse is having an extramarital affair. So if your patient is telling you that her husband is having an affair with another woman while he's living in a nursing home, it's probably not appropriate for you to try to confront her to convince her that he is not doing this. By the same token, a hallucination is a sensory experience of something that does not exist outside the mind, caused by various physical or mental disorders. We most commonly identify auditory or visual hallucinations in our patients. So it's important to determine if the hallucinations are disturbing to the patient, because sometimes they're actually not bothersome, therefore there's no need for an intervention. However, it is not useful or appropriate to inform a patient that the voices that she's hearing or the things that she's seeing do not exist. This actually might antagonize her even further. In thinking about walking away, if the patient refuses to bathe or take her medications, perhaps you need to walk away and come back later. But always treat the patient with respect and dignity. Remove the precipitant. There may be certain people that just don't seem to click with the patient or bring about some sort of negative reaction. Could even be a family member or certainly another staff member. Think about the time of day. Be mindful of sundowning or other times of day that your patient may typically become more agitated, irritable, or demonstrate changes in mood or behaviors. Think about certain places that might be uncomfortable for your patient. Understand the task failure. Offer reassurance and use distraction. Now, as we had noted with the lady who didn't want to go down to the shower room, she loves coffee. This was important for the staff to consider. So they started working on a plan in terms of how to use coffee to get her to walk down the hall. Other forms of distraction might include using reminiscence, offering patients their favorite food, and certainly providing them with their favorite music. Music works wonders. Other distractions such as puzzles, coloring, movies, dancing, walking or wheeling around the building, visits with pets can all be effective. The lady who stayed on her call bell constantly had loved gardening. So the staff began to think about how they could offer her some gardening projects. Even when the weather got better, she was able to go outside to do some outdoor gardening. Be patient. Use a steady, non-defensive tone. Avoid escalating with your patient. Stay calm. Say, "I'm sorry." Listen without judgment. When the patient talks about going home, don't tell her that she can't go home. Simply listen reflectively, acknowledging that you know she loves her home. Or if your patient tells you that she's waiting for her husband to come to see her later today, don't remind her that her husband died 2 years ago. Instead, encourage her to tell you about him. How did they meet? What were their favorite things to do? Keep your patient out of harm's way, even if it means sometimes having to block or grab hold of her. Learn caregiver protection techniques such as MANT. That happens to be the technique that we use here in our facility. This is a training that all of the psychiatric staff is required. It teaches techniques, both verbal and physical, to provide de-escalation to individuals who may be at risk for increased volatility, using the least restrictive approaches possible with an emphasis on keeping the patient safe. MANT doesn't necessarily have to be your choice, but I think it's important for all staff who work with geriatric psych patients or in long-term care facilities to have some kind of similar training. Make environmental changes. Is it too hot or too cold? Is the noise level bothering the patient? Provide comfortable clothes. Decorate with familiar pictures. Use soothing aromas or enjoyable sounds. Can't emphasize strongly enough. Develop a trusting relationship. Get to know your patient. Enter her world. It's almost like learning a whole new language. Provide activity and structure, both individual activity and in a group. Try to minimize downtime if at all possible. Perhaps a typical day in a long-term care facility might involve starting out having coffee with some of the other residents, then perhaps spending some time making Mother's Day cards. Then you may want to incorporate a little bit of time for exercise. And then perhaps after lunch have either a musical program or a reminiscence group. And then perhaps later on in the day as it gets closer to dinner time, put in some old videos of TV classics. Examine communication techniques. Now here's a whole slide of things to keep in mind regarding communication. Speak slowly in a low-pitched voice. Enunciate your words. Begin your conversations socially. Use short, familiar words and simple sentences. Talk in a warm, easygoing, pleasant manner. Ask simple questions that require a yes or no answer. Listen carefully. Give positive instructions. Avoid using don't or can't or negative commands. Avoid questions that require short-term memory. Rather than saying, "Did your son come to see you today?" ask a question related to a long-term memory, or make a statement like, "I hear you have a wonderful son." Give simple instructions. Did you know that there are 11 steps to brushing your teeth? Sometimes you have to give a patient step-by-step instructions if you want him to be able to brush his own teeth. Keep talking to the person with dementia, even if he can't talk back. Focus on a word or phrase that makes sense. And respond to the emotional tone of the statement, not necessarily the words. Stay calm, be patient. Engage family members for information about what certain words or phrases might mean. Respond as though you understand, even though you may not always understand. Try a hug or change the subject, and just say, "Wow." If all else fails, you may have to consider a geriatric psych hospitalization or medication interventions. Sometimes people jump to the conclusion that this is the first approach that needs to be taken, but we try to keep this as our last resort. Finally, we're going to determine whether or not our interventions were successful. Now, we may not reach a complete resolution, but as I said earlier, we want to minimize the behavior and the consequences as much as possible. And it may take several weeks to achieve some level of success. It's so very important to be consistent. Try to avoid labeling behavior that can hide the real problem. Labels such as manipulative, intentional, attention-seeking, childlike need to be avoided. Now let's get back to our two cases. No consideration had been given to the fact that the patient who was constantly on the call bell had significant cognitive deficits. She had had a stroke, which in fact had precipitated the placement in the long-term care facility. A cognitive evaluation confirmed that she was demonstrating signs of moderate dementia. This helped to raise the awareness of the staff about her capabilities, and thus their attitudes and expectations changed. She was also evaluated for a UTI, although that was negative, but it was determined that putting her on a 2-hour toileting schedule would be appropriate. She was offered and encouraged to participate in the facility activities and given the opportunity to do some indoor gardening with potted plants. And she was also given some opportunities to go outside. We determined and found out that she and her husband actually had owned a landscaping business. The staff stopped telling her that they had other patients to take care of, and they stopped telling her that she would never be able to return home. They were more patient and realized that confronting her was simply resulting in increased behavioral problems. Gradually and ultimately, her behaviors improved while she continues to have some episodes of agitation. They are less frequent, and the staff is managing them much more effectively. Now, with regard to the lady who didn't want to take a bath, the staff had not considered such issues as the time of day that they were attempting the bath, particular caregivers who were involved with her that were more successful with her, what her previous bathing habits had been. And so when they brainstormed and shared their individual experiences and successes with regard to the patient, they found out some of her likes and dislikes. And they developed a plan to use 2 of the people that she got along with more positively to typically be the people that were assigned to giving her a bath. They determined that this had a higher probability of success if they gave her a bath in the morning. And we also identified that she enjoyed drinking coffee. So one of the staff offered her a cup of coffee while the other staff took her by the hand to walk her down the hall, offering her reassurance. They were more successful in engaging her while she continues to sometimes refuse the bath. They are much more successful than they had been previously. So all the way through this, I think that you can see the theme of teamwork and how important that is. So in conclusion, the person with problematic behavior can actually be defending himself, paying someone back, letting someone know that he's had enough, telling someone he's in pain, or protecting something precious. The solution is to identify and stop what the patient feels may have started it, is antagonizing her, is hurting her, is threatening her, or is attacking her. Problematic behavior is generally not a vindictive action, although it may feel like an attack. The ultimate result is hopefully that the problematic behavior is reduced, improving the quality of life for the patient, and the caregiver-patient relationship improves, preventing compassion fatigue and caregiver burnout. I would strongly encourage you to buy and read these 3 books, which were important resources for this presentation. I think every facility and every caregiver needs to have these. And we've also included our contact information. We'd love for you to keep in touch with us if you'd like to collaborate or have questions or discuss cases. And we've included our email addresses here for you. Back to you, Anne.
Hello. Where are they? They're experiencing problems. Anne?
Oh, I am so sorry. I thought that I was unmuted. I'm sorry. I didn't mean to panic you, Beth and Cindy. I'm here. I thought I must have hit the wrong button. I apologize. I've never done that before.
That's okay. We thought we lost you.
Woohoo! No, I'm here, and I'm just prattling on, having a lovely conversation with myself. I apologize to everybody. Okay, so let me start back at the beginning. Thank you, Cindy and Beth, for these tangible and useful techniques. I know that our attendees have had a great learning today in terms of finding opportunities to to provide some new experiences for their residents and clients that they serve. So thank you for that. And I appreciate that in your final slide you did provide some reading materials for our attendees. So we do have a few moments of time here for question and answer. So if you haven't taken an opportunity to pose some questions, please take that opportunity now. And I will jump into some of the questions that folks have already posed throughout our session. So I think actually some of the questions that folks have posed were answered in the second session through this 4D approach that you've presented. And how I think that they're very grateful for that, because I'm seeing those responses coming in right now saying thank you for answering my question that I posed earlier. So let's talk about some of these questions that are still coming in. One of the things that we're talking about here in terms of questions that people have are about physical and verbally abusive behavior, and in terms of triggers and precipitating events. I think that we had an opportunity to address some of those, but would you like to say something more about triggers for aggressive behavior and how to best address those using the 4D approach?
Basically, when we're dealing with people who have histories of abuse, they are a lot more sensitive to provocation or what they perceive as provocation. And so a lot of the times, even though we aren't intending to present in a threatening manner, their interpretation is different. And so one of the issues that we see is that if somebody has a history of abuse in the past, they're a lot more apt to feel as if they're being abused again.
You know, I think that brings back one of the points that you both really drove home was the importance of a person-centered approach and becoming a partner and knowing the person's story and the importance of teamwork and how all of those pieces are so essential, not to just general quality of life, but to the day-to-day quality of life of the residents and clients that we serve.
Absolutely.
Absolutely right.
What are some of the things that you find so useful? You know, you've talked about how your whole team uses this 4D approach and really focusing on the precipitating events. What are some of the real success stories or take-home messages that you've experienced?
Well, as I said earlier, I think it's important for people to understand that when communicating with someone who has dementia, you can't always take the same approach that you would with someone who doesn't have a cognitive impairment. Sometimes you have to tell little white lies. Resisting or arguing with the person doesn't seem to accomplish much. Trying to convince them that the story that they're telling you happened a different way just simply antagonizes the individual. So once again, it's the age-old thing about meeting the person where they are, talking to them on their level. Go ahead and allow the person to talk about the fact that she's going to go home. The staff at one of the facilities that I work with had initially said, oh, but if we allow her to talk about that, we're going to give her false hope. But my response to that was, I think it's better for her to have false hope and feel more comfortable than to be confronted with the harsh reality that she doesn't understand anyways, that she's not going to be able to make it home.
Mm-hmm.
So once again, meet the person where she is.
Sure. And I think so many of the things that you pointed out, both of you, have been about really focusing on the person's quality of their day-to-day experience in a moment-to-moment basis. Yeah.
Right.
One of the questions that's come in is about tips to handle, to work with behaviors of individuals with alcohol-induced dementia. Do you find that there are differences across the different types of dementia?
There are. And a lot of times, depending on how severe the alcohol-induced dementia is, that'll determine what type of interventions you have, how much damage has been done. A lot of times, you can't really predict what they're going to be doing. They've lost parts of their history. I had, although we're a geriatric unit here, we've had people in their 40s on our unit who were severely impaired by dementia related to excessive alcohol use. One gentleman, his parents were both deceased, even though he was in his early 40s. He thought they were still alive, and he had to get home to take care of them, and didn't understand that. And like Beth was saying, it doesn't do any good to argue with him and try to reorient him. So the best technique that we found with working with him was to just distract him and to just talk about other things that were more positive. When he would say he needed to get home, we would ask him where he had been. And in his world, he had been at work, so we would go on and segue that into, what type of work do you do? And eventually he would forget that he was trying to get home to Mom and Dad. He would be so caught up in talking to us about what he did and what he liked about what he was doing that it kind of got us out of a fix, I guess.
Mm-hmm. Mm-hmm.
Another important aspect with regard to working with someone with dementia that's related to alcoholism, of course, is the attitude of the staff. Staff might say, oh, he's kind of done this to himself, and they don't have much compassion for him. But alcoholism is a disease, as we all know, and this is one of the repercussions of that disease. And once again, it's important for us to be able to meet the patient's needs and not be judgmental in providing care.
I think that's a great point. You brought that up earlier in terms of not having a paternalistic approach to the work that we do, and that is something that was echoed in our previous presentation about the ethical approaches. And so I really appreciate that, because that is the hallmark of a person-centered approach, not just in meeting people where they are, but also in leaving your own stuff behind, because it's not about us. It's about promoting quality of life of the people that we serve. And that's one of the things that I'm really appreciating about your presentation today. Okay, so here's an interesting question that I suspect you'll have a fantastic response to. That one of the seniors in who I assume is a resident where this person works is always trying to feed the animals, feed the pets. And how do you have some, whether that's their own food or pet food, how would you work with that type of behavior? Have you seen that before?
We don't have pets here on this unit, no.
Well, I'm not sure that the person is saying that they actually have pets. That's the behavior that the person is exhibiting. Yes, that's different.
We do have
right?
that happen here.
Yes. Okay, so tell us about that.
And
How do you, if the person is always trying to feed the animals, do you?
Absolutely.
Mm-hmm.
There are times, I mean, psychosis is very prevalent in dementia. Sometimes when they can't remember or they don't understand what's going on, they make up or they believe things that aren't based in reality. They may confabulate stories and buy into it, or they may become delusional about what's really happening. And sometimes they'll get so fixated on that that it's really hard to get them away from that.
Mm-hmm.
So we've had people who did that. We had a lady not too long ago who would take part of her dinner and put it in the floor every night because she was feeding her puppy.
Mm-hmm.
And there wasn't a puppy there, but she was feeding the puppy. So what we ended up doing was we would bring food for the puppy that she could give to the puppy so that she got to eat all of her food.
Mm-hmm.
But again, rather than trying to stop her from doing that, they came up with a way to allow her to do that. She wasn't hurting anybody. She may have been hurting herself by taking some of her own food away, but they came up with a mechanism so that she could get well nourished but still be able to have the satisfaction of feeling like she was feeding a pet.
Mm-hmm. Mm-hmm.
Wasn't hurting anybody.
Yeah. Well, and it embraced the meaning behind that behavior.
Right.
Right.
You know, and I was very impressed when you're talking about different activities throughout the day. You didn't say anything about bingo.
Oh, well, I guess that's so obvious. Everybody loves bingo and Pacino. Those are the highlights of the week.
And, you know, I'm grateful that everybody loves bingo. I am grateful for that. But, you know, Beth or, you know, Cindy, when I'm in your community, when I'm 104, please don't make me play bingo.
Okay.
And so one of the conversations that we were having kind of online in the conversation board was about the importance of meaningful activities and how important it is to have socialization and to have occupation, you know, to use occupational therapy language, to have occupation. And feeding your puppy is a purposeful activity. And that's one of the things that you're really driving home for me in this presentation today, that it's not just about having activity and it's not about preventing or stopping. And you keep saying that, and I really appreciate that it's not about stopping the activity. It's about taking that, or not about stopping the behavior. It's about taking that behavior where the person wants to go,
Right.
communicating what the individual is trying to communicate, because behaviors that we frequently label as difficult or problematic or challenging, it's really about communication. I mean, that's what I'm hearing you say. Am I right about that?
Exactly.
Absolutely.
Exactly. You know, we had a woman on our unit not too long ago who had been in the housekeeping department in another healthcare facility. And when she came to us, her behaviors were out of control.
Mm-hmm.
And our housekeeping tech found an old cleaning cart, brought it onto the unit, put a few towels and rags on it, a little squirt thing of water, and offered it to this patient. And she was in seventh heaven, and her behaviors diminished significantly. But there again, we were giving her something that she identified with, that was meaningful to her, and that was purposeful for her.
Mm-hmm.
And frequently we'll do something that will tie back into that patient's life story. So if we have someone who was an inspector, we can simply give them a clipboard with some paperwork on it, and they'll walk around and look at things and make their own little notes. Or we had somebody who was a postman, And so we made envelopes with addresses on them, and he got to deliver mail every day. So instead of making it a wander, we make it a purposeful activity.
You know, again, this is so immediately applicable to the work that folks are doing, and I really appreciate that. One of the questions that's just come in is about what do you recommend for working with families when it's clinically necessary that want no involvement in the patient's treatment or approaches to treatment? Do you have thoughts about, and maybe not specifically about that question, but about working with families as part of the team? Do you have some advice for our folks?
The biggest thing that I've seen in working with families is education and support. A lot of times people have a hard time dealing with things that they don't understand. Their easiest way of dealing with it is to just back away from it. So, I mean, we're not going to force anybody to be involved in the care of someone that they don't want to be, because that's going to convey that the patient or the individual that's being treated will pick up on that. But we try to give them information, we try to give support, we try to comfort them in their level and where they are in the situation, and include them as much as they're willing to be included.
And also to be able to give them permission to grieve, because it is a grieving process to have a family member, to have someone that you're close to going through the whole journey of dementia. It's a very long period of loss. And I think that that's important to allow families to acknowledge that it's a long grieving process.
Yeah. Okay. I'm looking through our questions here as they're continuing to come in, and I think we've addressed most of the questions that have come in that that weren't already addressed in the presentation, which were many. A lot of our questions were responded to throughout the presentation, which is a great sign always. But we do have just a couple of minutes left. Do either one of you have any closing comments or things that you want to make sure that our attendees have as take-home messages?
Well, just try to look at things from the individual's perspective. You know, if they're having some issues, some behaviors, I don't know that I've ever met a patient who was just acting out because of pure meanness. When they fight, it's because they don't understand what's going on and they're fighting for their life. If they hit, they most times misinterpret what's going on. So just trying to look at things from their perspective, and it'll help you better understand how to make the situation better.
Yeah, and remember they have dementia. That puts a whole new slant on the situation.
Well, thank you both again for these very tangible and useful techniques and your very person-centered approach. I'm always very grateful to hear that in the presentations that we offer to our attendees. So once again, thank you to you and thank you to our supporters. This event, again, was made possible through a grant from the Virginia Center on Aging's Geriatric Training Education Initiative and was supported by the Riverside Center for Excellence in Aging and Lifelong Health, the Virginia Geriatric Mental Health Partnership, and VCU's Department of Gerontology. Please don't forget to complete your event survey. This is what will enable you to receive your certificate of attendance. Be sure to download the slides after the fact if you haven't already done that for sharing. And remember that all of our webinars are archived for future viewing and sharing as well. I hope that everyone has enjoyed this webinar, not just today, but in terms of this series that we've offered through the Geriatric Mental Health Partnership. And I hope everyone has gained something today that will help you do what you do a little better. Thank you so much for your time and attention. Have a great day.